We had I remember when I was a resident, there was a patient whose parents were Jehovah's Witnesses, and the little child had leukemia, and the parents refused to let the little child have a transfusion. And after much discussion, we eventually had to get a court order. You know, that we had to get the hospital lawyers involved because it was life-threatening for the child. So it depends on what it is. And then in another instance, here in California, in the community that I practice, there was a Jehovah's Witness man who had a bleeding ulcer, so he was very sick, and he refused a transfusion. And during his hospitalization, he was trying to regain more blood cells, iron production, so he could get stronger. He lost vision in one eye because there was not enough blood flowing from his heart to his eyes. So we just treated him for that episode, you know, giving him eye drops and pills, and he got some vision back. But he was accepting of this. Mm-hmm. He still did not want a blood transfusion. Mm-hmm. So one has to get the patient to understand the risks and benefits, mm-hmm. and it's written in the chart that they, he understands, and there's a witness. There's a witness for the mm-hmm. hospital, witness for the patient, so that they're fully aware. Mm-hmm. So lucky for him, he eventually went home and had some recovery of vision.
Mm-hmm. So in your practice, how do you bridge the cultural differences personally?
Well, in our practice, we've been fortunate in California. We have a big diverse population, so we also have a diverse population of employees who can bridge that gap. So we have translation services. We provide the Asian languages, Chinese, Cantonese, and Mandarin, and we provide Tagalog, the Filipino language, mm-hmm. and we provide Japanese, mm-hmm. and we have Russian, mm-hmm. and we have French, and on some days we have Vietnamese. Mm-hmm. So we mm-hmm. try. Mm-hmm. And it's worked. People respond to that, and they like bringing their elderly grandparents to our office because we try to bridge that gap.
Mm-hmm. And how do you respond to cultural ageism?
Oh, cultural ageism. This is very common in ophthalmology. As an ophthalmologist, we see the majority of our patients over age 65. And we are very aware that as we all have more birthdays, we all become either walk slower or we have delayed cognitive function, which is very common. And I'll have to pick my own nursing home too someday. But what happens is that I think that we try very hard. We will even walk them to the parking lot. We take extraordinary care of our seniors. We mm-hmm. sometimes have somebody sit with them if their home health provider leaves them and just drops mm-hmm. them off. Mm-hmm. And we make sure they have water, magazines to read. We'll read to them, mm-hmm. if they mm-hmm. Cannot read. And they can also watch the fish in our fish tank while we amuse mm-hmm. them. We talk to them. We tell them about what's various eye conditions. We give them reading mm-hmm. about that. We try to engage them. And we also try to make the visit as efficient as possible mm-hmm. because we know that they don't have a lot of patients sitting there because they're infirm, they don't feel well. We will call a cab for them. We try to go more than just the normal. We go the extra mile. We really try because we know it's uncomfortable.
Mm-hmm. Getting back to the law, and we touched on why it was passed because of this book was written. Can you give us a little more historical background about Clinton's involvement in that?
This book was written by Ann Fadiman in '98. It was she won the Pulitzer Prize. She won a lot of journalism awards, and within 6 months, this book in particular was discussed in New England Journal of Medicine, which is our '1 journal that every doctor in America reads. And it was the front cover of that journal. I remember reading it, and as the pen was mightier than the sword, she got everybody's attention. And it really made us realize that there were cultural divides. Now, in California, we have a very diverse population. We've always had a diverse population, 30% Asians. We have Hispanics, 30% Hispanics, and we've had major waves of immigration since the gold rush. So for us, the types of interpreters have always been available, but let's say in the Sun Belt states where more of infusion of different immigrants from different cultural backgrounds, this may not have been as accessible. And in addition, 1998 was the time when, well into the 1990 census, just before the 2000 census. And it was the 2000 census that showed us the various changes in the population groups of America. So for the first time in history, we realized that there were large Asian populations in Louisiana, in Texas, in Washington, D.C., in Maryland, Virginia, which people never really thought about. They thought all the Asians were in California, end of story, and everybody else was the rest of the country. So these people also had higher incidences of diabetes, and not to mention more Native Americans using the American health system, and also the growth of the Hispanic population. All these people had big diabetes problem, and they were not taken care of back in their home country. And then when they came here as immigrants, they had severe diabetic complications. So they were flooding the healthcare system, and that's where health literacy played a role too. So not only they didn't speak English in some cases, or some of them spoke English but read at a low third grade level and could not really understand what it meant for us to deliver the type of care. You know, you have a blood sugar of 600, 6 times normal, you have to be hospitalized, and the family members were aghast that this could happen. And so it was the changing of our demographics in America that made this law really potent, and that now we're in the Census 2010 stage, where again we will see that America's population has diversified, and then the need for cultural competency is even greater, because now we have more Arabic-speaking immigrants, Muslim immigrants, and people who have served in Iraq, Afghanistan. We've brought over Afghani refugees, you know, for health care, and Iraqi injured refugees. So we're seeing that we must take this to a new level almost, because before we were aware of the post-Vietnam War settlements. Mm-hmm. So now we have to really be prepared for the post-Iraq War settlements. Mm-hmm. And that's, again, awareness, attitudes, skills, and knowledge that we have to bring into play. Mm-hmm.
So this law is a federal law?
Yes, it's a federal law that affects all federal hospitals. That means VA hospitals, veterans, and then any hospital that receives federal funding. Mm-hmm.
How do you see the new healthcare plan changing some of the funding issues of the hospitals with regard to that?
You know, it's very interesting. You know, the healthcare proposals are evolving, and I don't think the problem will go away, because the sick people who seek emergency care are sometimes the people who were disenfranchised from the medical system, did not have the proper prophylactic care, like, you know, prevention care. And so when they come into the system, they're very sick, and then there will be the language barriers. So I think we will have even more language barriers that we as physicians must see. You know, people who speak only Arabic, and there are different dialects of Arabic, and their cultural beliefs. We'll have the Muslims, and, you know, different types of Islamic sects, and how they view medicine, modern medicine, because sometimes they will feel it's invasive, and that again they believe that it is time for grandma to die, and this is okay, and where we may think, oh, we don't view it like that. So again, it's awareness of these cultural differences.
So you see over time the use of medicine and the way of delivering medicine has changed in general in view of these cultural differences.
Oh, definitely. I think people are becoming more sensitive, and people are aware that for these people, maybe we just have to get them to agree with what we think, or some midway point.
So how do you do translating, in a sense, from doctor talk to patient talk? To patient understanding, not talk, I'm sorry.
Well, we try to, you know, we try various ways. When we involve the representative family member, usually in certain